Tonight's presentation is sponsored and presented by Physicians for a National Health Program, Minnesota. We are an organization advocating for universal, comprehensive, single-payer health care at the state and national levels. We aim to restore the primary mission of physicians acting as professional advocates for patients. Tonight, our moderator will be Dr. John Crossan, retired pathologist and co-chair of the Minnesota chapter of Physicians for a National Health Program. John, would you like to introduce our panel?
Yeah, thank you, Jen, very much for that introduction. I want to welcome everybody to this webinar. We think it's a very important one, particularly right now as we're going into election time. Jen, I want to thank you for organizing this webinar and putting it together. I'm going to just start by saying that healthcare delivery in rural America and in rural Minnesota is suffering right now. And I think the one figure that points this out more than anything else is that the life expectancy of people living in rural communities is 3 years shorter than the life expectancy of people living in urban communities. It's 77 years for people in rural communities and 80 years for people living in urban communities. This summer, we were privileged to be able to have 6 of the first-year medical students do an internship with us, and they studied different aspects of Medicare for All and different aspects of healthcare delivery. 2 of them concentrated particularly on rural healthcare, Zara Shakur and Tim Youngacha, excuse me. And they're going to be with us tonight as panelists. And we have 2 other panelists. Barrett Fitzgerald is a member of the board of PNHP Minnesota, and she's now a 4th-year medical student. And she's had experience in rural Minnesota several times on her clinical rotations. And finally, we have Dr. Nelson Adamson, who is a radiation oncologist in where are you again, Nelson?
Monticello.
Monticello, excuse me.
So just a little bit outside of the Twin Cities.
Yeah, right. So we have different aspects of rural healthcare that all of us will be discussing. We're going to start with Zara Shakur, who actually will be kind of reviewing some of the other issues with rural healthcare. So Zara, I will turn it over to you.
Sounds great. So I'll just start off with giving a brief snapshot of the healthcare resource disparities in rural Minnesota. And in general, rural Americans face greater health disparities when compared to their urban counterparts. And when we're looking at Minnesota, 80% of rural EMS agencies rely on volunteers. These are not paid positions, and usually they're difficult to fill, especially when it comes to filling holidays or weekend shifts. And since a lot of these EMS programs are also not adequately funded, the lack of payment and also the lack of resources means that there's a decreased incentive in living and working in these areas, which again feeds into the low income problem. And then also many of these volunteers also hold other jobs, and therefore they're overworked, which increases their likelihood to make mistakes, which speaks to the quality of care that can be provided with limited resources. And then in trauma situations, 88% of agencies provide basic life support and not paramedic level support to their communities. And then rural Minnesotans also face severe shortage of all provider types. And the few that I do want to highlight are OBGYN, pediatricians, and psychiatrists, where less than 14% of all commercial healthcare spending in these areas, less than 14% of all healthcare spending is on primary care. And then again, given the shortage of primary care, this population is less likely to receive well-child visits or preventative care such as mammograms, pap smears, colorectal screenings. Also, they're less likely to get medical advice about exercise, healthy eating, and smoking cessation. And then if we could move on to the next slide. So this population is also more likely to experience potentially unavoidable hospitalizations for conditions like hypertension and pneumonia that are treatable with primary care. And 44.9% of all heart disease deaths could have been prevented in most rural areas. That's almost 50%. That's a really high number. And then 80% of rural Minnesota counties have mental health professional shortages as well, where rural communities have higher mortality rates for suicide than their urban counterparts, again, due to the lack of services in these areas. And then maternal mortality rate is also higher in rural Minnesota, where in metropolitan areas, the figure from 2018 was 18.2 per 100,000 live births. But in rural areas, this number jumps up to 29.4 per 100,000 live births. And throughout our internship, some of the more prominent stories that we heard from patients were that patients had to drive much further to receive prenatal care, even though there was a hospital nearby them. And this was mainly because of mergers where OBGYN services were usually amongst the first to get cut. And then if we could move on to the next slide. So we're going to talk a bit more about the consequences of the resource disparities. And we've mentioned a few, but rural Minnesotans have more chronic conditions. Sorry, if you could go one slide up. Perfect. So rural Minnesotans have more chronic conditions. They report poorer health status, and they experience higher rates of frequent mental distress and suicide. They also have to travel further to receive inpatient healthcare services, especially mental health and OB services, as we talked about. And then rural patients also suffer a higher rate of excessive death from heart disease, cancer, diabetes, respiratory diseases, stroke, COPD, and suicide. And also unintentional injury deaths are approximately 50% higher in rural areas than in urban areas. And this is partially due to the greater risk of death from motor vehicle accidents, as well as the opioid overdose crisis. And again, all of this is due to the inadequate resources to handle these situations. And then these populations are also more likely to experience a 40% higher preventable hospitalization rate of chronic conditions and a 23% higher mortality rate than their urban counterparts. And a recent CDC study also found that children in rural areas with mental and behavioral and developmental health face more community and family challenges than children in urban areas with the same disorders. So then, can we move on to the next slide? And then another study found that rural Minnesotans were more likely to be told by the clinician or by the clinic or a doctor's office that they weren't accepting any new patients because of limited resources. And again, another story that we heard time and time again throughout our internship was patients coming in with tumors who were delayed in being seen even though they had symptoms. And there's several barriers to that. So we talked about doctors not accepting new patients. Some of the patients couldn't travel to be seen by a physician. Some of the patients said that they didn't have insurance, and so they didn't feel like they could go to a hospital because they couldn't afford out-of-pocket payment. And the list can honestly go on. But by the time these patients are seen and are diagnosed, the tumor is already metastasized further, either to a point where it's more expensive and more invasive treatment is needed, or to a point where nothing further can be done about it. And then the last point I wanted to make is that although telehealth is being used more, and especially we're seeing more of it with COVID, it still has its barriers. And one of the barriers I wanted to highlight was it really doesn't benefit the more resource poor areas. And again, these are the rural areas. So as you can see from the graphic shared on the screen, the light green area shows the underserved areas, where a third of Minnesota by population and 2/3 by geography don't have access to broadband internet, and 15% of Minnesota has no internet access at all. So that concludes my points.
Thank you, Zara. I just wanted to make a comment that came through on the chat, and one person commented they were wondering why a woman has to drive from Grand Marais to Duluth to have a baby. And this was a point that you made, and it's a very serious point and problem in rural health. Our next speaker is Berit Fitzgerald. Berit has spent several of her clinical rotations in rural Minnesota and has had some experiences that she's going to tell us about. Berit?
Thanks so much, John. So I'm a fourth-year medical student at the University of Minnesota, but I grew up on a family farm in central Minnesota and spent several years farming before going back to medical school. So farmers and farming communities are near and dear to my heart, and I'm going to talk a little bit more about issues that are affecting farmers in Minnesota, but I think they highlight a lot of the issues that are facing rural communities all across the US. So in Minnesota, 96% of farms are family owned, which means that farmers have to figure out their own ways to access health insurance since they're not getting it through an employer. So typically, there are a number of ways that farm families access this. Often that comes down to one partner in the farming family to have to get a job off of the farm. This can often happen naturally if one partner is farming in town, or sorry, not farming in town, but working in town and is able to get employer-based insurance. But oftentimes this isn't the case, and there are many farm partnerships where both people would ideally be farming, but someone ends up having to work off of the farm simply for the sake of being able to get health insurance so that they are able to protect themselves and their families. Another option is an open market health insurance, which we'll talk a little bit more about in a minute. And then there's some new forms of cooperative insurances that are sort of springing up in rural communities that I think try to appeal to the sense of coming together and supporting one another. But really all those take are kind of a single person in those small networks to get seriously ill, whether that's a cancer diagnosis with long-term immunotherapy, or in these days, someone who gets COVID and is in the ICU for an extended period of time. That can really make those financially burdensome for the individuals who are participating in those. And one story that I wanted to highlight is the president of the Minnesota Soybean Growers Association, Jamie Bayer, gave an interview last year talking about his family's insurance. It's a family of 5 here in Minnesota, and they have to pay $1,500 monthly for their premiums, and then they have a $13,500 deductible. So if you're doing the math, that's just over $32,000 before they would be able to access full coverage if someone in their family became seriously ill. And that's relevant if you look at this chart here that looks at the average income of Minnesota farm families. The average income is just short of $64,000, which means that almost half of a family's income would have to go towards healthcare costs just to keep going annually if someone has an ongoing illness, which I don't need to explain why that's not financially solvent for farmers. And so in a single payer plan, people would be able to pay in based on their income at a level that they can afford as their income expands or shrinks as the farm markets shift. If we go to the next slide. And so farmers who are seeking out plans on the open market, and this is true for any anyone in rural Minnesota who is buying insurance on their own in the open market. They tend to have higher copays and deductibles. And in 2017, rural premiums on average were 10% higher than those in urban areas. And for example, a premium for the ACA Silver Plan could be up to 40% or more in rural areas compared to urban areas. And this is becoming an increasingly important problem for farmers specifically, as we are now in this kind of new era of a farming crisis in the United States. Since 2014, global commodity production has outpaced demands, and prices for American farmers have really decreased. Example for corn, which is a large part of Minnesota's agricultural economy, has decreased by 44% in price without really much change at all in the production cost. And so farmers are really struggling in a new way, and healthcare costs have just continued to rise in a way that's just becoming more and more unequal and burdensome to farmers in rural America. And so single payer would be an option to remove this burden again. If we go to the next slide. And one thing this could be a topic in and of itself, but I just wanted to highlight very briefly, was hospital closures. So for farmers in rural communities to access healthcare, they both have to be able to afford their insurance, but then they have to physically be able to access the care. This is a statistic I think probably a lot of you have heard about, is 174 rural hospitals have closed across the United States since 2005, and 19 of those were just in this past year alone. This graph shows the blue dots are hospitals that closed from 2005 to 2010, and the yellow ones are from 2010 on. And so these closures have both the immediate impacts in the communities of people not being able to access critical care, obstetrics care, emergency care, but it also has larger impacts on these rural communities, as hospitals are large sources of employment and economic viability in communities, as well as a huge potential for rural communities to recruit and retain young people, as well as retain people who are aging and thinking about their health needs as they grow older. So hospital closures are a huge issue across the US, and in our current healthcare system, we have no real sustainable ways to support these hospitals. For example, one way that we are currently trying to do that is through the critical access hospital designation. Of the 98 rural hospitals in Minnesota, 78 are considered critical access, where there's not another area or another place for people to access their healthcare if these hospitals were to close. But in 2017, almost half were at risk of closure due to finances. And we know that with COVID and with as these rural hospitals have been hit by having to close down surgical units, and they already operate at much smaller margins, that there is going to be a long tail to the COVID pandemic, and how these hospitals are going to already struggling are now going to be hit even harder. And so under either the Minnesota Health Plan or through a single payer insurance plan, there are specific funding mechanisms that can focus on supporting rural hospitals and rural communities based on need rather than profits. And as we're currently seeing, that system is not working out. Back to you, John.
Forgot to unmute. Thank you, Barrett. Actually, there's a question that came in that I think both you and Zara may want to comment on. The question deals with, are transportation services a part of the solution for having travel distances? And I think the other part of that is, are the lack of transportation services part of the real problem there? And I guess what they're getting at is that a lot of small towns don't have Uber, I don't think. Would either of you want to comment on that?
So small towns, they don't often have Uber, but there are taxi services. There are some community funded sort of rural bus routes that you can call and get specific transportation, but those are generally limited within a county. And those are seen just as hospitals merge and as resources are being taken out of a community, it's not enough. But transportation is certainly an issue in rural communities, but is not kind of the full piece.
And there's one other comment here, which I'll just briefly summarize. This person said they messaged their state senator and talking about how unaffordable 2021 premiums and deductibles are. And they say it's time to say no more to the big health insurers who think these rates are okay. And that's just another comment that somebody threw in. So thank you very much, Barrett. That was a good overview. We're going to go on now to Nelson. And Nelson's going to tell us a little bit about a couple of patients that he's been in contact with.
Thank you. Thank you, John, for moderating, and thank all the other panelists for all the comments, and you've sort of set the stage for the information I want to share. And it's kind of a personal information. It's kind of based on my experience as a practitioner. I'm a radiation oncologist, so oftentimes I see, almost always, I see patients that have been through the system and have been diagnosed, and they're at the point at which they're going to have some treatment to prevent recurrence, or treatment to often for cure, sometimes for palliation. But two patients kind of came to mind that had rather dramatic stories, and I think they sort of highlight some of the really problems that our current employer base and insurance system that is often doesn't exist for some patients, and when it does exist for others, it's not adequate. So I don't know, I think my slides are here. So the first patient is illustrates how lack of insurance can really have an impact on care. I met her, I believe probably I met her towards the advanced stage of her illness, but just to kind of give you sort of a snapshot. So she was 62, I believe, when she first became aware that her employer was going to drop her from the insurance plan. So basically, she was working for a very small manufacturing company in rural Minnesota, and they were she was covered under her employer-based insurance plan, but because of cost, and that's one of the things we've talked about today, the cost of the plan just became untenable for her company. So her option for insuring herself at that point was to go onto the open market or to sign up for one of the plans that are available for patients who have limited income. And she was approaching her Medicare eligibility date. She said, well, I really can't afford this. Why don't I just wait until I become eligible for Medicare and I'll get insurance? Unfortunately, she found a lump in one of her breasts in 2012. And at that point, she was probably 2 or 3 years from Medicare eligibility. So she did not have insurance at that point. So she said, well, maybe this will go away. Well, it didn't. You can advance the slide. And she actually go back one slide, my apologies. So she waited about a year. This she didn't seek medical attention, she didn't have insurance. And she developed a lump in the opposite breast. So at the point at which she enrolled in Medicare in 2012, which was 2 years after she first noticed the lump, her evaluation revealed stage 3 breast cancer on the right side, stage 2 breast cancer on the left. So instead of having to undergo a very simple procedure, she had to undergo a very complex surgery. She needed chemotherapy for 8 months. The 2 chemotherapy drugs she needed were adriamycin and paclitaxel. And you can go to the next slide. She had to undergo a bilateral mastectomy. I saw her after all of this had been done. She needed radiation for 6 weeks. And this was and hormone therapy for 5 to 10 years. So the point I'm trying to make is if she was insured and if she had access to an affordable insurance plan 2 years before she felt the initial lump, she may have avoided a lot of these treatments. These treatments are costly. These treatments are toxic. I don't see her regularly now, but I am aware that she does have a cardiomyopathy, and it's probably likely that the cardiomyopathy is due to some of the chemotherapy drugs she required. It also could be due to the radiation. So things that may have, be avoidable with treatment that was done earlier. She also has a peripheral neuropathy, which is a very painful and debilitating condition. It also may have been avoided. So the second patient I want to talk about is someone else I saw in 2012. She had stage 0 breast cancer, which is very favorable diagnosis. Probably close to 100% of these patients are treated and they survive and they do very well. She underwent a lumpectomy, just removal of the lump. Radiation is usually indicated after a limited procedure like this. She completed the radiation in 2012. She was placed on a drug called tamoxifen, which is generally taken for 5, maybe 10 years. And the reason for taking it is to prevent recurrence. I remember her really well. She's a very lively person. She works at a restaurant that's a pretty good restaurant that's in the local area where my practice is. And but unfortunately, the drug was too expensive for her. She simply her insurance did not provide sufficient means for her to pay for it. She just couldn't afford it, so she took it for about 8 months, and she stopped. And she discontinued it basically due to cost. Next slide. So fast forward about I think about 3 years. She had mammograms as she should have, 2013, 2015. But in 2016, she had an abnormal mammogram. Now, at this point, she had stage 1 breast cancer in the opposite breast. She underwent a lumpectomy, a lymph node biopsy. She took post-op radiation, so now I'm giving her radiation for a second time. Had she taken the tamoxifen, she may have avoided this completely. I can't guarantee that, but it's very likely she would have. So it's and she's been placed on Arimidex. Now, fortunately, she has a different job this time, and she has a better one, and she does have a better insurance and employer-based insurance, and she is going to take the Arimidex to prevent a further recurrence. So these sort of patients that I personally know, and there are probably many other stories that I could tell, but it kind of highlights what the impact of not having insurance at all, or having insurance, but that's inadequate to provide for the recommended treatment. So I think, I would like to see a single payer system. I think situations like this should never happen, and they're totally avoidable if we had a better system in place.
Thank you very much, Nelson. It brought to mind several things. And of course, the first thing your first patient brought to mind is the fact that with the pandemic, millions of people have lost their job and therefore have lost their health insurance coverage. And so this issue is much more of a problem now than it was back at the beginning of this year. I do have one interesting question which I had not really thought about, and I'll open this up to anybody who wants to comment on it. Question is, would reintroducing home visits be an option to lobby for? I haven't really given much thought to this, and I don't know that any of you have, but anybody have any comments on that?
Yeah, I think any, I mean, this is kind of an old-fashioned, it's sort of a Dr. Welby kind of story, kind of the doctor taking a black bag and visiting someone.
Well, that was when I was growing up, Nelson.
I think any kind of expanding the system of care so that we can have more people with access, because I think probably one of the problems with home visits is whether or not they're reimbursed adequately. I think that's been one of the real issues. Physicians probably are, and I said there are probably also liability issues as well. But I think probably for us to kind of have a system, I mean, I think it's done in other places in Europe. I understand in France that's a very common situation. Physicians actually visit patients at home.
Yeah,
I think probably it'd be a great idea, because sometimes what you learn about a patient really becomes your understanding of the situation improves a great deal when you see where they live. Sometimes maybe that's a part of our kind of getting to know someone that we miss out on.
yeah, that's a great point, Nelson, that I'm going to talk about later. I have a question right now that is a wonderful segue to our next speaker. And the question is, how does Medicare for All HR 1384 remedy each of the hardships and wrongs? That is exactly what Tim is going to talk about now. So Tim, I'm going to turn it over to you. Thanks.
All right, thank you, John, for the introduction. Next slide, please. So I'm going to talk briefly about how a single payer system could address many of the issues that rural Minnesota communities face. So in an ideal system, all medically necessary care would be covered. That would include inpatient and outpatient services, dental, vision, long-term care, mental health services, and pretty much any care that a patient would need. It would eliminate the burden of copays and deductibles, so any form of cost sharing, and it would finally give patients the freedom to choose their doctor or their hospital as well, which is not always the case now. Hospitals would be funded through annual global budgets, which would be based on communities' health needs. So specifically regarding 1384, which I'll be talking about in 2 slides from now, those funds would be dispersed and reviewed on a quarterly basis, and there would be regional directors appointed who would provide an annual healthcare needs assessment of their communities in consultation with public health officials, clinicians, patients, and patient advocates. So these budgets would be flexible, and in the event that a region or hospital would need additional funding, those funds would be available. Those would be able to be requested and allocated in events of emergencies, like a pandemic, for example, in a public health crisis of any kind, or in any situation where patient volume exceeds capacity or funding. It would also prevent closures, and for hospitals that had to cut services that were traditionally reimbursed at lower rates, they would be able to restore those services and provide them for their patients. And I will be talking about obstetrics on the next slide. Thank you. So as one of the panelists already touched on, if you look at the left graphic, you can see that from 2003 to 2018, 9 Minnesota counties lost hospital birth services. And if you look at the graph on the right and compare the two, you see that most of those counties were in rural communities. So if we were to transition to a single payer system, those services would be funded and patients wouldn't have to drive hundreds of miles or a very long distance to receive the services that they need. And in doing so, that would address some of the disparities in maternal and infant health and mortality as well. Next slide. Thank you. So we already talked about this briefly, but there are bills in the US House and Senate around Medicare for All, but I'll be talking about HR 1384, which is the Medicare for All Act of 2019, which was primarily sponsored by Representative Pramila Jayapal. And it, in summary, establishes an improved Medicare for All national health insurance program. So the bill would create a national health budget that would have three components: a capital expenditures budget, an operating budget, and as Title VI mentions and is mentioned at the bottom, a special projects budget for purposes of allocating funds for capital expenditures and staffing needs of providers located in rural or medically underserved areas. So this is a very important clause because, first of all, it would provide rural facilities with the resources that they need to renovate existing facilities and construct new facilities based on need. It would also allow them to purchase equipment. For example, some counties in Minnesota lack mammography screening machines, and in having a national health budget, those facilities would be able to purchase them and be able to provide very important breast cancer screening services for their patients. It would also directly address the issue of provider shortages, which has already been mentioned, especially in obstetrics and psychiatry on the basis of funding, and it would provide further incentives for providers to practice in rural communities. A final point is that it would alleviate the financial pressures on rural hospitals and clinics to be absorbed by larger conglomerates based on debt or other financial considerations. And as I believe Barrett mentioned, hundreds of rural facilities have closed since 2005. And by having this budget to ensure that those hospitals are staffed and are up to date, that would prevent those closures and allow patients to have readily accessible care. In terms of what we can do now, my quick blurb would be to contact our local elected officials and urge them to support this bill and similar bills at the statewide and national levels. And for more information, you can go to the PNHP national website, which has great resources on how to start these conversations and how to mobilize. And with that, back to John.
Great, thank you very much, Tim. That was a very good overview. I have a couple of interesting comments here from the chat room. If I can pull it up again. Hang on just a minute. One of the comments is that single payer financing would allow us to develop a statewide plan for care system design and better integration with public health, and that I definitely agree with. And I'm going to briefly comment on the Minnesota plan in just a bit. Another comment, which is very interesting, and I'm going to want to talk about this a bit more. Home visits are very common in Cuba. And I don't know whether any of you are acquainted with the Cuba health system, but it is a fantastic system, actually, in many ways. And we won't really have time to go into it, but it is a system that actually makes sure that everybody has a primary care physician, make sure that they have at least one visit a year to a local clinic, and it has a very good tertiary care system. And so the Cuba system is really interesting, and of course was developed under Castro. Any other comments or questions at this point in time? If not, I'm going to jump in and comment on something that Nelson mentioned. Nelson mentioned that it might be of interest to be able to see a person in their own environment and trying to understand their disease. And what I think he's saying is that many social issues contribute greatly to the health of individuals. And I just saw a statement from the CEO of Fairview today, which I thought was fascinating in a number of ways. Number one, he commented that the Minnesota Hospital Association, looking at the emergency room visits to the Fairview system, felt that 72% of those visits could be avoided if we had a proper primary care system available in the Twin Cities. And obviously this would reduce costs tremendously, because anytime you set foot in an emergency room, you are already starting to run up a big bill. So the cost to the health system would be greatly reduced if we had a proper primary care system in place that people could access. I want to comment on another point that that the CEO made. He says that the Fairview system is changing a number of things in the system. Some of you may be aware that Bethesda Hospital was set up as the COVID hospital, one of the very few unique hospitals in the country set up just for COVID patients. And they're going to change that shortly. And what they're going to do is to turn the Bethesda Hospital into a place to welcome homeless patients and give them some shelter during the winter months. And one of the reasons for this, of course, is that if you are in a homeless shelter, the chances of transmitting COVID from one to the other is huge. And so this would reduce the number of COVID-19 infections, but it also would make lives much easier on many of the homeless people that we have in Minnesota. This is being done in coordination with administrative people in St. Paul. And the other thing that they're going to do is convert St. Joe's Hospital to a common hub of health and wellness. So what they're going to do is stop providing sick care in St. Joseph's Hospital, but actually provide wellness, education, and health care instead of providing sick care, because this is not needed in St. Paul because they have plenty of other first-line hospitals there. And this, to me, is a major change in the corporate hospital concepts. And everything we've talked about today primarily has to do with the corporate hospital systems trying to make as much money as possible, and therefore they eliminate obstetric care, they eliminate psychiatric care because neither of these are profitable to them, and they close hospitals because hospitals are not profitable. Whereas Fairview now is trying to address the primary issue of healthcare. So I was very impressed with this. I don't know if anybody else is aware of this or anybody wants to make any comments about it. I see another question here. Let's see what that says. I can't, oh, here it is, yep. So a friend of mine asked a question that I knew would be asked. would a state single payer system be financially viable? And that's actually a great segue into what I was going to comment on at the end of this. So let's move on from that, and I'll get to that shortly. Would functional medicine focusing on prevention be a more affordable way to address rural health? For example, Dr. Tabatha in Michigan has great recommendations for ways to prevent breast cancer through healthy living. That's exactly what I was trying to talk about. We would reduce costs tremendously if we emphasized preventive medicine rather than sick care. And this also includes updating our public health systems. We have taken a big hit in public health systems in recent years, and public health systems clearly need to be updated. This would be a tremendous improvement in the ability of us to recognize and to prevent diseases just as they emerge. So, yeah.
Hi. Yeah, I was just going to just highlight that a bit, and I kind of totally agree. We don't have so much as a system that the incentives are wrong in the way our system is currently configured, because we pay physicians and hospitals and providers for actually doing things, because the incentives are really totally wrong. I mean, just as an example, I mean, if you counsel a patient for, say, an hour to stop smoking, or perhaps counsel a patient for an hour, perhaps to maybe get out and exercise and lose weight, the reimbursement for that is very, very low. But if you're, say, a specialist who maybe does colonoscopies, or a specialist who maybe does, if you're a radiologist, you do mammograms, the reimbursement for doing a colonoscopy is just, you can do several of those per hour. You get paid very well for doing this. So I think the incentives in our system are wrong. I mean, I think we probably should somehow figure out a way to encourage, physicians, providers, they could be mid-level providers, whomever, to prevent people from, first of all, from becoming ill. And I think that requires some effort. And I think there's so many social determinants of health. There's just so many more. But I think the way our system is structured now, we get paid for doing procedures. And perhaps that's kind of the wrong way for our system to be modeled. And but that's probably going to take a really big change. I think in all the single payer systems that I'm familiar with, I think the emphasis is on prevention. The emphasis is on care that's to keep people healthy rather than providing care once they become ill.
Entirely agree with that. It seems to me that we in medicine are here system over out to make as much money as possible. The pharmaceutical companies, the insurance companies, the big conglomerates who are buying up hospitals, their sole purpose, make as much money as possible and to make a very high population. Jen, let me go on to the next slide, can we? There was a question about the Minnesota Health Plan, and I'm sure a lot of you are aware that Senator John Marty in Roseville has had a very strong Minnesota health plan in the Senate for many, many years. It's unfortunately never come up for a vote, but maybe it will after November. The Minnesota health plan, next slide, is a single statewide plan that would cover all Minnesotans for all their medical needs, just like 1384. Patients would be able to see the medical providers of their choice, have comprehensive coverage, not be required to complete complex application forms, and never again worry about how they will pay for their prescriptions or whether their treatment is affordable. The plan would be funded by all Minnesotans, meaning that everybody would pay something depending on their ability to pay, and would also be funded by companies to supplement the charges. The reality is that half of healthcare right now is paid for by the government. If you look at Medicare, Medicaid, and the VA hospital, there's already a lot of money in healthcare, and the rest of the money to provide a single payer system would be provided in these ways. And we would get rid of the terrible administrative costs that we currently have to pay. Next slide, or is that it? Oh, yeah, the next slide gets at maybe one of the reasons we're doing this webinar, and that is some of you may be aware that there is an election coming up next month. It happens to be on November 3rd, and for those of you who believe that single-payer healthcare might solve some of the problems of rural health and also some of the problems of urban health, make sure that the people you vote for actually have stated that they are in favor of this. There are many legislators running for the legislature, the state legislature right now, who have stated that they favor single-payer healthcare, and so it's worthwhile checking with them before you put your vote in. But anyway, don't forget to vote by November 3rd, and everybody can actually vote earlier. Let's see if anything else has come through on the questions. So somebody says Fairview will also open empath, emergency psychiatric assessment treatment and healing across the Fairview system. Yeah, I actually was aware of that. I didn't comment on it, but that is something that that Fairview is going to be doing. And we've already commented on the fact that psychiatric care in rural Minnesota and in rural America is sadly lacking, and it's extremely difficult for people in the rural communities to access good psychiatric care. They're also restructuring their PCP clinics, closing many and consolidating to 16 health hub locations and expanding virtual visits. Great. That's referring to the Fairview system. Somebody else says it is difficult to find a physician who will treat with nutrition and exercise, and it is expensive. Insurance does not pay for that. That's exactly true. That's a great point. Any other questions that people would like to ask? Jen, have you seen any that I have not covered?
I did see a comment in the chat. It says that the Blue Zone project in Albert Lea has shown improvements for rural health, and that maybe this could be a blueprint for other communities. Does anyone have any comments on that particular project?
I don't know about that. Anybody?
Yeah, I know a little bit about it. I don't know sort of what the mechanism of expanding that, but I think kind of at the heart of it is looking at community-based solutions. And I think through a single payer system, we can more, we can incentivize more primary care and more preventative measures, like what they've done in the Blue Zone projects, where they've focused on building, my understanding is they've done things like building community walking groups and working with restaurants to work on like healthy options and building sidewalks and things to make like walking paths accessible. And I think that kind of all of that gets at to how are we incentivizing things in our healthcare system. And right now, because it's so profit, in order for rural places and all hospitals to be financially solvent, they have to be very focused on profits, and like Dr. Adamson was talking about. So that really incentivizes procedures. So doing a colonoscopy for something that's could have been prevented much earlier is hospitals get more money through that, as opposed to thinking about more public health and primary care interventions. So I think it could definitely be.
Yeah, Dan Buettner is an interesting guy. He has studied a number of communities around the world where people live longer than average. And he's tried to figure out what led to their longevity. And the things that lead to longevity are the things we've already talked about: a good lifestyle. And this is not rocket science, but he's actually done studies that actually prove this. And now I was aware now that they were trying to open something like that up in Albert Lea. And this is what Nelson and I were just talking about. The environment is so important in a person's health. And we in medicine should be involved to some extent in trying to improve social situations, but particularly to provide preventive health care. Here's some comments about some legislators, and I'm not allowed to comment on that, but there are people who have come out in favor of Medicare for all. Thank you for that comment. And somebody says, listening to the health provider issues, it comes to mind that it needs a collaboration with transportation services and broadband, name just two. I mean, improving health services in rural Minnesota needs a definite plan, which it definitely does. We need to be working on this, and hopefully we get the legislators in place in November who will be able to do that. My own personal view is that if we have the right legislators in place in November, that Minnesota can be the first state to actually have a full single-payer healthcare system or Medicare for all. And I think it's probably likely that it's going to have to be state by state before it becomes a national. I think it's going to take a lot of effort to make it national. But if we can be the leading state and show that it works, that it provides better health care for everybody, and that it leads to better lives for everybody, I think the country will follow along. And that kind of takes us up to 8 o'clock. I don't want to keep people from other things tonight, so I want to thank the panelists very much for everything they did, for the audience for asking some great questions, and for Jen for organizing this. Thank you all very much. Have a great evening.